for tutoring anyways. Like, I don't know.
Yeah,
I feel like so mean though. When like sitting there like, hey guys, we gotta go, dude. And then the accelerated students packed up and left at noon on the dot. I'm like, how is that fair? Taking this silly thing off. I'll never have to put it on again. This is my last time in this building. You guys brought me back here for my last time. Deuces? Yeah. Later, dudes. Okay, so this last exam is the easiest.
Oh,
I was told it was the hardest.
Really?
Okay, it's the hardest because you don't have
But it
your
seems
EKGs to
easy.
buffer you.
Yeah.
Easier.
Yeah.
It
You
seems
don't.
easier.
For those
is
of you
what
who
I
did
said,
well in
but-
patho with Margie,
Is it the same exam?
the shocks and stuff, you're gonna get it if you know your stuff from patho, which I think some of you do.
Okay. What do you guys start with? Renal or
Renal.
Sure.
Yep. You guys are gonna have to know all of the weird signs. Grays, Turners, Kerrs, Cullens. I was like, I know it was the hot vampire's last name.
That's what I remember too.
He's really not that hot anymore though. It's just,
Not now, but
Back
my
when-
lady was.
okay.
Even though I think it'd be like statutory rape. So know when it comes to the kidneys, you need to know your CBA tenderness for the pyelonephritis. I'm probably not going in order just because I'm looking at my notes and I have a buttload of notes on these. So Grace Turner's that bleeding in the retroperitoneal area. You're gonna check it after like the cath lab, after kidney or blunt trauma.
No, if you have a patient with periorbital edema, what does that usually signify?
Nephrotic syndrome.
The way I always remember nephrotic and nephritic is nephrotic with the O. Just think protein, nephro, O. I don't know if that helps you, because if you lose proteins, what are you going to do? What's your main protein? Albumin. If you lose albumin, you're going to double space. So nephrotic syndrome, that's
Double
the
space.
syndrome where they're, what did I say?
Double space.
Double space. Third space. Dude, my brain is gone. Okay, but if you're losing protein, that's what it is that you're losing protein in your urine and glomerular or nephrotic syndrome, okay? Nephrotic.
So like I said, with nephrotic, think the periorbital edema, and then with that pyelonephritis, think that CVA tenderness, and then they get fevers, chills.
Because what pyelonephritis is an infection of the upper urinary tract. So the lower urinary tract would be what? Would be your urethra. And the upper would be like the renal pelvis almost, and then the top of the ureter. Does that make sense?
And then the only thing that she talked about, she probably showed you guys the X-ray with the Wilms tumor or the kid with the giant ass. Like she said, pathos tutors, you're not allowed to answer this, and we weren't allowed to answer any of these kidney questions because they're the same as patho.
Yeah.
So Wilms tumor is common in kids. Good prognosis, found early, ends up growing to be giant.
You should know like what we're gonna look at in their labs with kidney problems. So you're gonna look at BUN, you're gonna look at creatinine. I would know that your BUN to creatinine ratio, what is it? 10 to 1, and if it's 15 to 1 or over, it usually signifies pre-renal failure. Know what diet you're gonna put kidney failure patients on, because that's when she's gonna have on there. It's like high calcium.
The diet's a little later.
Oh.
But with this, you need to know what falsely will elevate your BUN, like a GI bleed and dehydration. Creatinine is more specific. You need to know the osmolality concentration, right? Isn't that the one you need to know? 275 to 295? You need to know one of these numbers. Your anion gap, that's indicative of a metabolic acidosis. H&H. Your electrolytes, you're going to focus on. Potassium's the big one. Calcium, because
Why? Why am I hypocalcemic when I have kidney failure? Why phosphorus and calcium are always going to inversely relate. Okay, so why am I specifically though? Why?
You're retaining phosphorus and it's going to bind to calcium.
But there's another
There's
activity
why
that kidney
is
does.
calcium going to be
Vitamin D.
low, especially
Yes.
chronic vitamin D. So if I have chronic renal failure, vitamin D is activated in your kidneys, and if I don't have vitamin D activation, I'm not going to absorb calcium. If I'm not absorbing calcium, I'm going to be hypocalcemic. So you gotta
these
remember that
kidney
too.
failure patients typically they typically maintain their calcium at the expense of their bone because of parathyroid hormone.
Until their phosphorus gets high.
Because their
of
vitamin D
maintenance.
isn't allowing them to actually absorb that calcium.
Does that make sense?
And you already said phosphorus. Okay. The lab assessment.
If there's microalbuminemia, whatever, we test that for diabetics to see how their kidney function is, because diabetics tend to, especially diabetics
greater
that don't
risk
have
for-
good A1C, they are at greater risk for kidney issues. Because you shouldn't have albumin in your urine. That's a protein. Okay, so that's all the first page.
I think I got it right there. Okay, so you guys need to remember your calcium, because she's gonna put in questions about. She's not gonna say your patient's in renal failure and has hypocalcemia. It's gonna say your patient was in renal failure and presents to the emergency room with tingly lips. And when you put on a blood pressure cuff, her hand turns inward. That's Chovestic, or that's Trousseau. That's indicative of hypocalcemia. So you need to remember the signs of hypocalcemia. So Chovestic sign is tapping the cheek. Trousseau is that carpal pedal spasm, or their hand turns inward. They have increased neuromuscular excitability, twitching, tingling.
So they're gonna have low calcium, high phos, high potassium, and high acid. So they're gonna be acidotic.
Because the kidneys play a buffer system as a buffer system for your pH, for your pH. And they excrete potassium.
So you need to know the different types of renal failure. So pre-renal is anything before the kidneys. So if I'm in shock and I'm not getting blood flow to my kidneys, I'm in pre-renal failure. If I am severely dehydrated, or if I have hypertension, that's all pre-renal. It's all before the kidneys, okay? Now, however, don't get confused, because shock can also cause intrinsic. How? Because if you're not getting the blood flow, or shock can cause both, because pre-renal is the blood flow is not getting there, okay? But if it's not getting there and the kidneys aren't perfusing, it can also become intrinsic, because then it's a hypoxemia thing in the kidney. Does that make sense? Okay, so you need the glomerular filtration rate. The glomerulus is very sensitive to pressure. So anything hypertension will also injure the kidneys. But pre-renal, always think like shock, low blood flow. That's always before the kidneys.
Yeah, and then intrinsic, think ischemia. So lack of the blood flow over time is going to cause the damage. Nephrotoxic effects of drugs in general.
Such as like contrast.
Tubular obstruction, and then toxins. So
And what
tubular
causes
obstruction.
tubular obstruction? We've gone over a couple things. The one, what's it called? Sorry, the tumor lysis syndrome. That can cause
and
it.
then like a muscle trauma, myoglobin, like a crush injury.
called? Yeah, rhabdo. And rhabdo can cause intrinsic through obstructing the tubules. And then post-renal failure is really easy. It's like there's calculi, it's stuck in the ureter, or you BPH in men. Something so that the urine cannot leave the kidney. The urine, think about the urine backing up in the kidney and causing it to fail. So post is always after the kidney.
Okay, so she has the ATN, acute tubular necrosis course, differentiate between Porth and Erden. Doesn't matter as long as you know that during the recovery phase or the diuretic phase, urine returns, but it doesn't mean the kidney's back to full function. Once you see your urine, doesn't mean that the renal tissue is completely back to normal function, basically. I just repeated myself. So just know, I don't know which one she uses on the exam. Erden calls it the diuretic phase. Porth calls it the recovery or convalescent phase. It's when you're going to see urine, but it's not necessarily completely
Your kidney's
healed.
not bad.
Yeah.
So you need to know your diet. So restriction on protein, phosphorus, sodium, potassium, and fluid. The disease states that put you at risk for renal failure should make sense. The heart failure would, because not only does hypertension, but hypotension can also, because the kidneys are sensitive to pressure, whether it's low or high. Okay, so heart failure, hypertension, diabetes, those are all going to increase your risk.
Okay, so you guys need to remember CBIG kid. You guys are gonna, on the exam, there's gonna be a EKG of peak T wave, and the very next question is going to say, what are you going to give this patient? It's going to be something along the lines of what's in CJ kit. So, calcium. Why do we give calcium? Well, it's an antidote. It increases the function of the heart, and it's an antidote for increased potassium. What causes the heart issues that increase potassium causes the calcium kind of like X's it out. Insulin is to push the potassium into the cell, and then glucose is to counteract the effects of the insulin. Caxolate is going to, however you give it, is going to cause crazy elimination in the feces. And then dialysis, or sometimes they give a diuretic, and that's just to get rid of the potassium. So know that, because it's going to literally be like 3 of those things after the question.
You also need to know that it's the acute renal failure. We don't necessarily jump as quickly with our H&Hs with their low hemoglobin, because these patients are already sensitive to pressure and they're more than likely going to be anemic. So we don't usually transfuse or give them like recombinant DNA or anything like that, like an epigen, until they're like under 10 or something, like lower than the norm. Like you and I would get it at a higher level, but because they're in renal failure, we don't want to increase their blood volume, increase their pressure, further hurt their kidneys. Does that make sense?
With dialysis, I mean, the big thing is just knowing that.
I mean, I don't
I
remember.
don't even think so either. I think peritoneal, the only thing is making sure that you're keeping the site clean, because
They can't get it
Yeah.
back if they lose
good
it.
question about maybe if you're going to give an antihypertensive during the days of dialysis, because they're removing a bunch of fluid. So I don't know if you guys have ever had a patient on dialysis, like after they come back from dialysis, they feel like shit. They look like crap. They're pulling a bunch of fluid off of them. Typically these patients they in general have to be stable. If they're unstable, or you're in the ICU, or they're in any way, shape, or form have cardiac instability, they're going to get CRRT, because that's a continuous remove and replace. It's a constant. They're never pulling too much off. And then with the peritoneal dialysis, know about the site.
So when you give the antihypertensive after dialysis, when you hold it?
I would hold it until after, because you don't want, if their blood pressure's, because there's always going to be a parameter on an antihypertensive. So
Well, there should be.
there should be, yeah. I mean, it's going to say, like, don't give a systolic under 100 or something. So when they come back, if they're extremely hypotensive, you might hold it for the day.
For clinical
just-
reasons, when you're in the hospital, if you have patients on dialysis, generally a nice resident will put in for the medications, hold on dialysis day, or give on, like, you'll have it. And when I interned, I had a lot of patients that would go to dialysis, I'd just call. Be like, hey, they have dialysis today, if I didn't know.
Just know that they're pulling a bunch of fluid off of them, which is going to put them at risk of hypotension to begin with, and then you're going to, like, give them a drug to drop them even lower.
But for antihypertensives, then I would generally hold until they at least get back, and then I'd check their pressure.
I went through and tried to learn all these stupid CRT methods. Don't.
Yeah, like
Don't
all the
waste your time.
abbreviations. Didn't she put those in your quiz though? Any of them?
One of them, the CVVHD.
Yeah, and that stressed me out, and I was like, what the heck?
I just picked it.
Yeah, me too.
So,
Okay, so we already know diabetics are increased risk for renal failure because of the diabetic nephropathy. So that's why we would test for microalbumin in their urine. We give diabetics, we generally put a diabetic on an ACE. Why? Because it's renal protective. It has renal protective properties.
See, I'm telling you, the first indicated, like, someone said ACEs and ARBs indicate even some of the texts said it doesn't.
Well, it depends. It does protect or injure.
Injure. And
Well-
then the book it said it doesn't, like,
I have written down ACE inhibitors might prevent renal failure because of the vasodilation.
Which slide is that on?
And I've read, I mean, I guess it
just have
depends
in
on
my
how,
notes. I wrote it down, margins to set it out loud.
I've always been told and always taught that ACEs have a protective kidney
Yeah,
effect. However,
ACE, vasodilation too.
I know, impact kidneys, prevent CKD. However, I think that one of the side effects of it are renal problems. That would maybe be if you're keeping their blood pressure too low, or I don't know, you know. But for the most part, it's a renal protective effect.
So you could see a patient on an ACE to prevent remodeling of the heart and to prevent chronic kidney disease. That's what I've learned in this semester. Oh, that was 2 years ago. But I memorized the chart. I don't know if she told you to know it, but I did.
I always just knew it and have them.
0 through 5, the stages of CKD. I memorized it. I don't know why. I didn't know if she said it was on the exam or not, but I don't remember if it was.
And everyone here that's over the age of 25, you're already losing renal function.
That's exciting.
Thanks.
It begins to decline.
It begins to decline. I'm already. Good thing the liver is what's affected with alcohol, right?
Yeah.
Okay.
So this is just all the issues that can come from having crappy kidneys. You end up with excess fluid because you're not excreting properly. Infection, like they're super itchy. All my end stage kidney disease, they're like, I want my Benadryl pushed fast before my Dilaudid, pushed extra fast with a flush even faster. That's how they always, because Benadryl supposedly makes the Dilaudid work better, but they're always super itchy.
And it gives you a little high. Yeah, well, they're itchy. Liver failure and kidney failure both cause itchy.
It's because of all the toxins
all the
that
waste.
remain in their blood.
And then in liver failure, it's because of the bile salts.
Okay. Like,
Okay.
you guys should, if you understand how the kidney works, you're gonna understand that they're gonna have anemia because they lack erythropoietin. They're gonna have hypocalcemia because they lack that vitamin D. They're gonna have elevated phosphate. I would go through and just make sure you know
Since
that.
they have increased volume, they're gonna have hypertension. Since they have hypertension, they have an increased volume. They could end up in heart failure because their heart's working harder.
They have metabolic acidosis because they're not making the bicarb excreting the hydrogens. Okay, so just know the there, that's what I love these little things. Okay. Just know the little chart at the end. I like that thing. Okay, GI.
I have no idea what is true there. I don't know what that is.
So do you guys, I don't know if you guys can remember how to differentiate between the stress ulcers, between Cushing's and curling. Cushing's is you typically head trauma. Curling is basically anything else, but more typically like burns, things that cause high stress. Trauma, burns.
Cushing's is what again?
Cushing's is in your head.
Brain injury.
So think of Cushing's triad.
Oh.
That's
There's
why I
3
was-
Cushing's. Cushing's triads. Cushing's from having too much cortisol, and Cushing's stress ulcers. And it's in your head.
Curling is trauma.
Curling is the
burn
like,
or trauma.
curling's like where they're at risk for at the hospital right now. Just like your patient that's on prophylactic
Mhm.
because they're in the hospital, they're under more stress.
You got to know hematochezia. I just call it hemorrhoid cheese. What? It's like the easiest way to
It's
remember.
fresh. Why? Well, that's disgusting. Fresh bleeding from.
Bright red off the anus. It
Yeah.
says on mine out with my writing. Melena is the black tar stool because it's already been digested at that point. That's why it's black or dark brown. H&H's are unreliable because if we dilute it, then they're going to be they're going to be lower if they're diluted.
Well, and at the same time too, you know how they take an H&H is that they just take a sample of your blood, centrifuge it, and then see the comparison. Well, if you're losing a lot of fresh blood at once, the percentage is going to stay the same. Does that make sense? It's going to be a while until your body starts making more serum to fill your vasculature. Does that make sense to you? Any of you guys what I'm saying? So you're going to have to lose a lot of blood or a decent amount of blood before your H&H actually starts to drop with it.
Okay, so if we talk about the liver, and when we're assessing for ammonia levels, if they have too much ammonia, we're going to do the flapping or the asterisks. Make sure you know that. To decrease the pressure in the liver, that's causing
Portal
what are these
hypertension.
called?
Oh.
Varices. Then we do what's called a transjugular intrahepatic portosystemic shunt, and it's instead of our body making its own collateral channels, it's kind of a way of decreasing the pressure by
So we're talking about
putting it somewhere else.
we're talking about liver failure.
Yes.
Okay, so all the blood from your GI system, stomach, intestines, and all that is filtered through the liver. So when your liver starts to fail, it backs up. So what she's saying is your body kind of tries to make like detours around the liver, and that's what esophageal varices, hemorrhoids, caput medusae, all those that's what those
She
are.
doesn't even like go into like liver failure. Why does she just go right into tips?
I don't know.
Why don't you talk about liver failure first?
I don't know.
Okay.
Tips is another way that we can go through and bypass that. Bypass the liver. That way
Decrease the pressure.
we can decrease pressure. And then, wow, she
I
does
think
go right
we
into
come right back to
pancreatitis.
liver failure. Okay, so we're gonna
Yeah,
put
she
liver.
comes back.
We're gonna put pancreatitis right in the middle of this. Make sure you guys know the hypocalcemia again. So if you didn't understand Chauvet-Sixtine and Trousseau back when we were talking about it with the kidneys, you need to know about it with the pancreas as well, because it precipitates in the fat necrosis around the pancreas.
Pancreatitis is life-threatening, super, a lot of pain.
Autodigestion.
There's that argument about morphine and is it Demerol?
Demerol versus morphine and the
Yeah.
sphincter of OD.
Morphine makes the sphincter OD spasm, but they don't really do that anymore. But she wants you to know it for your boards.
Make sure you know the Cullen sign, that purple and around the umbilicus. I hate that word. I just only say it because next semester you guys are gonna hear her. What's her name?
What?
Kraft Blackshear. What do you guys? The umbilical cord, right?
Umbilical cord, right? That's what it's called. I don't know why all of a sudden people are like umbilicus
Umbilical cord.
She calls it umbilicus. And I
all
hate
the
it.
time. The
Okay.
umbilicus.
All right.
Umbilicus? Like to me, umbilical
She
cord.
She also put in bold something about NG tube being optional. Personally, if you see a patient with pancreatitis, they're all going to be on an NG tube and lower intermittent suction.
And why are they
because
MPO?
So to stop
Because, yes,
secretion.
Because
You
you
don't-
don't want to keep you don't want to cause the body to digest more because they're just going to
Yeah.
keep digesting their own pancreas.
'cause
So
it's
you don't
your
want to
pancreas-
stimulate
You're
your
going to keep
pancreas.
giving like amylase, lipase, protease, and it's just going to keep eating itself. Because
So you want to give the pancreas a break so you don't let them eat.
I don't think there's that much on pancreas other than that. Pain control, take the food away. Okay, fulminant hepatic failure is like hepatic failure for like it's abrupt. It's not because they've been,
Drinking a
drinking the
pack a day.
bottle for like 3 years and hey, your work burned down, dude. What the
Yeah.
fuck?
I forgot about that.
Sorry.
I don't know.
I just saw her. Like, did you work there still?
Yeah.
Are you
Oh
gonna work
my-
at the union? They're offering all you guys jobs.
I got a job at the firehouse.
Woohoo!
Yeah.
Good for you.
What burned down?
Her restaurant she worked at.
Dude,
Sorry.
Dude, another gas station
Dude,
burned down.
you
I
never
know,
even
a
got
couple
me
weeks
my
before
brie. You said you were gonna hook me up, girl.
What restaurant?
Where'd you work at?
Lakes
Girl.
and
Yeah.
Dixie. We're Clarkston. I'm Clarkston. Yeah, but then the gas station like a couple weeks before that. Like, what's up
Yeah,
with all the
I know.
fires? You guys
Yeah,
have arson?
in Highland in Boyne Highlands just burnt down.
Are you serious?
There's too much oxygen in the air.
Money.
How's the Tennessee wildfire traveling?
Okay, sorry you guys.
No, it's
I
fine.
just
I was
saw
like,
her.
where is
I
this?
just, like, saw-
Abrupt. Like, what the fuck? What happened?
I was like, oh my god. Okay, so fulminant hepatic failure is when I think of that, I think of like Tylenol overdose. Like it's or infection. It was pretty abrupt. It's not like long term abuse. What are we gonna give if they have Tylenol overdose?
Come on, guys. Mucobus, which is
Acetylcysteine.
all
acetylcysteine. What's the real word? So the liver has 100,000 million functions.
specifically 400.
400 functions. It controls some glucose, so your patient can end up hypoglycemic. It controls a lot of proteins, specifically albumin. So
Why
you
does
have
it control
edema.
albumin? Because albumin is made there, synthesized in the liver.
Yep, it has clotting factors, so your patient will be bleeding. Something with cholesterol, I can't read. My eyes hurt.
It also
Yeah.
synthesizes fat soluble vitamins, and it
Bile
also
salts.
breaks down fat because it creates bile to break down fat in your diet. So if your liver sucks, you're not gonna be making bile. You're gonna have steatorrhea, which is fatty stools. But there's like a million
It
things.
breaks
Why
down
are you-
ammonia, so you have with hepatic encephalopathy. That's why we do the asterisks thing. We break down drugs. It's bilirubin, so you see jaundice. So make sure you kind of understand because she can throw any of these things at you. So
Did they ever tell you about what happened to one of our students with Ginger?
No.
She was like grilling us. She's like, all right, what's the liver do? We're like, that's not fair. There's like 400 different things. She's like, start naming a few. And then like everybody got stuck. And our guy named Jagger was just like, he turned bright red when he gets nervous. She looked at him. She's like, what does it break down, Jagger? He's like, and then she starts flapping like a chicken. And, you know, protein. And he said, chicken! And she just said us something. She's like, she just started laughing. She's like, go home. I'm done with you guys. So now every time every time we see Jagger, it's like, what's the liver do? Everybody goes chicken.
oh, it's alright. I thank God I never got called out like that. My one time on MedSearch 1, my instructor was like, "What's BMP?" And I didn't know.
Brain injury peptides.
Well, no shit. We learned.
Well,
it.
no, Ginger never called me out because I was the person that was always like, and then
Oh, look,
she's like,
on the
shut
next
up.
slide, it says
Okay.
everything I just told you guys.
She's like, what do you think about this? I was like, oh, it could be this and it could be that. You can do this and you can
I
do this.
just
And
asked
walk
her
away.
a question before she could ask me one.
Me too.
I
I
thought
always
it was
said-
You told us.
I
that.
told you guys to do that, didn't
Yeah.
I?
Not me. I just did that.
Because I always said it for if you guys want to get along with Ginger, just when she walks up to you, always have something to say or something to ask about, whether it be assignment, pull it out of your butt.
Yeah,
'cause
she came at me hard one time with this look on her face. And so I just asked her some quick stuff, and she's like, and then afterwards she's like, I don't remember what I was gonna say.
that or she's like, hey, what was your patient's sodium today? And you're like,
What's sodium?
2?
So the next slide that I'm looking at is the pathophysiology, that like the encephalopathy I was talking about, the jaundice I was talking about, bleeding, hypoglycemia, decreased lactate clearance just puts them at a greater risk for metabolic acidosis. And then know that bolded cerebral edema and increased intracranial pressure from the breakdown in the blood-brain barrier and astrocyte swelling. So they have an impaired blood-brain barrier. So they have increased ICP.
Because you know that bilirubin is not permeable to the blood-brain barrier, and bilirubin is damaging to the brain, which
But
is why
if
our Billy
they-
babies be worried about because their blood-brain barrier isn't mature like ours. So the breakdown of the blood-brain barrier increases issues with the brain.
So the headache and personality changes we can attribute to the increased intracranial pressure and the ammonia. Hyperventilation can attribute to the acid.
What? Brina, you always answer too quickly.
Sorry, acidosis. Jaundice you can attribute to the bilirubin. Palmar erythema is those red hands. Spider nevi or bruises, because they have coagulation issues, right? They don't have those clotting factors. Edema because of the lack of albumin, and I already said the asterisks are liver flaps.
Are the spider meatballs the same as that long word? Telling.
Telangiectasia.
Yeah, is that same?
I think so.
Telangiectasis or whatever the
Yeah.
heck it's called.
Oh, probably.
Sure, why not? Why don't we ask Mr. Smart Guy over here at the end of the hat?
What up?
Look at me, I'm not with
Yeah, it is.
Okay, it's the same thing,
It's
right?
gonna be the same thing. It's just a fancy way of saying it.
Telangiectasis.
You see it on your nose.
That's like the
it's
hominopsia.
hominopsia.
Hominopsia. You guys know what I'm talking about.
So
Yeah,
basically,
Yeah, I
we
know.
manage these patients by removing the waste. So we're gonna give them lactulose, which causes massive diarrhea, like explosion. We're gonna prevent bleeding, and we're gonna treat the bleeding if they are bleeding and replace clotting factors like FFP and vitamin K.
Okay.
What causes the erythema again?
The red hands? I have no idea what causes the pulmonary erythema. What causes the red hands?
Probably something that has to do with
Toxins?
there's a bunch of hormone issues with liver failure.
You can find out if you really wanted to, but it's not an exam.
Yeah, it's not an exam. We'll tell you it's not an exam.
GI. Just so you know, she skipped all the rest of
I'm
these.
sure you guys have all seen liver failure patients.
Mm-hmm.
Oh, they,
No,
they
I
suck.
know.
It really sucks.
Yeah, mine died too.
Okay. I would go to the hepatic injuries.
Yeah, I was, wasn't I? God,
Wait, what?
my last code we got her back after a round. It was really good. I was like, I wish the students were here today. This was a happy ending. Then Brianna got her, and she's probably dead now, though. She aspirated
Well, no,
so
I
much
was like,
vomit.
code. I want her the code, but then my preceptor was like, she's coming to our floor, and I'm
Yeah,
like,
the ICU
okay, I'll
team-
get the room ready, and then I got to drop her. And
See, you guys got to see a very organized code. When codes happen on the ICU, it's like a very fluid. When they happen on 7 East, the code team has to run there, and then the nurses are all just kind of like, and then
They
they go
like
hide
hide
in the
corner,
hallway.
and you're like at a code, and you're like, can I get a blood pressure
And then there's,
machine?
like-
and no one knows where one
Oh,
is.
God.
And there's-
well, they're probably hidden.
Well, there's like 4 of us that are the ICU team, and we're all like doing everything, and then I don't think they know what to do, so they just go hide, and you're like, oh, I'm so sorry. And I want to like pull them in, like, come here, let me teach you about this, dude. But then they're hiding.
Okay, I would not. Well, I don't even know why you have something written there. Let's just.
I don't
go to
know.
this one.
Oh, yeah.
So
those are
hepatic
short
injuries,
subjects.
upper.
Know your
No,
pains. Know
if-
where you're gonna
yes,
feel
if-
pains.
know where your organs are. So upper right is your liver. So if you have upper right quadrant pain, think liver, gallbladder, right? Upper left is what? Your spleen and pancreas. And then if you want to get to lower, it's like appendix and then like diverticulitis and shit, but you don't need to know lower, I don't think. But you need to know hepatic injury and splenic injury.
Left versus right.
Yep. So one is just upper right quadrant pain. They're gonna have the guarding, hypoactive or absent vowel sounds, and then with like splenic injury, you need no curse sign. So it's pain and radiating to left shoulder, upper left quadrant.
And if you have a splenic injury, you may see signs of hemorrhagic shock because a laceration of the spleen in trauma is common because where it's located in relativity to the ribs. So, if you puncture your spleen or lacerate your spleen, you could bleed out.
And
We'll
then
get
just
there, though.
know that if your 10th or 12th rib is fractured, you're at risk for the spleen.
And liver. Depends on the side.
Yeah.
So she might say your patient's got a fractured rib on this side. You need to know which side, which organ's on because you're gonna need to say you're worried about that organ being affected.
Or if you're a passenger or a
She had
driver,
those
you
on
get
the
it.
quizzes like 6 times.
Okay, good.
What was it?
Well, if you're what?
The
If you're a passenger or you're a
locations of
driver, and you get
pain,
hit from the driver's side or the passenger side, which one's gonna be most affected?
shoulder.
That's what
Sure.
she talked about.
Did you talk about death in the compartment? I remember talking about. Oh, really? Oh, because she's like your assessment in a trauma. We'll get to trauma. But when you talk about a trauma, you need to know certain things because, like, if I walk in and I'm perfectly fine, but I was just in a car accident and there was a death in the compartment, which means somebody in the compartment died. If it was significant enough that somebody died, then that person needs to be worked up a lot heavier than you would normally
Yeah.
assess them,
The
just because they
mechanism.
walked in.
Mechanism of injury, sorry.
They may be hidden somewhere, internally bleeding. What am I doing?
Moving you. So with your renal or bladder and urethral injuries, just know that you're not gonna put a pulley in if they have blood at the meatus. If their prostate is free and high, then you need to check for bladder injury,
On a man, obviously.
unless a woman has a prostate.
Has anyone seen that Chicago Med?
Yeah.
Yeah. Where is it? He's like, wait, this is a prostate.
Make sure you know 4 to 6 units lost for pelvis and 2 units per femur.
Specifically, an open book fracture is going to lose the most amount of blood. If it's an open book pelvic fracture.
Is she just gonna say somebody has a bilateral femur fracture with a pelvic fracture? How much is that off? That was in Path when she did
That was
it.
in patho. She does that.
2 3.
She does you're riding a bike, you fall off and you break your neck. What types of shock are you in? And it's both. You could be both neurogenic and hypovolemic because the guy like lacerated his spleen or
There's
something.
a one that's a double. All right, endocrine. This should be easy because I feel like by now everyone should know diabetes.
We talked
So-
about a lot.
I hope so.
So know like your A1C. Cool.
You'll get
Oh,
diabetes.
this is the
together.
number you need to know. Yeah,
It says
285 to
4 somewhere.
295.
Yeah, 4 to 6 right here, and then it says under 7 somewhere.
Yeah.
What?
What is it?
For
For
A1C?
A1C,
Yeah.
it says 4 to 6% is normal, but for diabetics, it's under 7. Is that?
Because you want an A1C under 7 for a diabetic. You have to be 6.5 to be considered pre-diabetic, and then they don't just look at your A1C for diabetes. They usually look at your fasting glucose. So once you have diabetes, you can have an A1C of 16 or an A1C of 6 and still be considered diabetic. You could be a type 2er and lose 100 pounds and have blood sugar better than I do and still be considered diabetic even though it's resolved because you'll always have that.
Right. Okay.
So the
Okay.
normal scores.
Normal
They
scores.
just
Yes.
want it under 7.
Yeah.
For a diabetic, yeah.
He said 6.5 is when they're considered diabetic.
No, 6.5 is pre-diabetes. That's when they're gonna start working you up.
Know the definition of what the heck insulin does.
I hope you know what it does.
Glucocorticoids.
What does insulin do?
None of that stuff. You don't need none of that. I already said this, and I already said this, and this thing you don't even understand. I'm here. I already said that.
Do we have small these?
I don't even know what you're reading.
They're bolded.
I know.
Oh, you might. Hey, did she have that question on heart failure?
Which one?
Which one?
Yeah.
That one where they're like, which of the following is true? And it
The
was
Volvo maneuver, the nutrition one.
no,
No, it was under 65% or over
under
65.
the one where I
No.
told you guys there was like
No.
$1 million on this or no?
That's dumb.
Because
I
remember
was
I told you
looking
guys
for
that
it.
that's what she did. She pulled it off a stupid slide like that where
Yeah.
she highlighted facts. And I was like, oh my god, I'm supposed to memorize facts.
Dang it. So
Okay, but were any of the questions we told you guys here?
Yeah.
Yeah.
The Valsalva
They just
one.
said that
I
one.
didn't get to read and everything you said was on there. Mark answer.
Oh yeah.
Yeah, I never read it. either.
We took
Yeah.
this class 2 years ago. I've
Tell
driven
Margie you
along.
read it.
I just don't tell her
She's
anything.
there. She's like, you're reading that.
I
She said that about
yeah.
the exam. I'm like, fuck, I didn't read anything this
Me neither.
semester.
I know.
did
I
I don't
graduate in
understand.
like 4 days, so I don't think I ever.
I wish I
I'm
had
not
time.
starting out.
I
Unless
wish
this
I
was
had time to
yesterday.
read. I would love to read.
I'm just letting you guys know last semester synthesis, I didn't open a single book.
We don't buy books for synthesis. Synthesis requires that you have
All of your
all of
old
your
books, but I
books.
never opened a single book.
all of our old books.
Yeah,
You
like
don't even
your-
have tests or quizzes
don't
or
need it.
nothing.
really,
I'm so happy.
I
Like
googled
synthesis-
everything. You just gotta know about drugs. You so stupid. I mean, it's awesome. It's the best class ever.
It really is the best clinically because you're like a nurse. Like
that's what
I
you
just
guys
took a
told me. I was
position in the
synthesis.
CCU and I'm in the CCU right now and I literally do everything. So I'm just continuing to do everything with the same girl now. Only I get paid.
But no, but synthesis class is so
Is
useless.
so
But it's the best clinical you will ever have. But the class itself, you don't do
And then
anything.
leadership is awful. Make sure you read your PowerPoints. I probably wouldn't have failed. I failed.
Okay, and I'm gonna give you a
Just so
pearl.
you know, I
I'm
lost
gonna.
my 4.0 in leadership.
She
and
now
I
has a
made mine.
3.98. Okay, I'm letting you guys know a little pearl for synthesis or for leadership. Don't freak out in the first 2 exams because the last 3 exams she lets you do open book.
No, was 2.
Oh, was it 2?
She drops your
Five
lowest.
exams.
Who's
And-
who's the professor?
Erica
Erica
Rhodes, and
Rhodes.
she's. Oh, you guys may not be there. Wait, when? They're only in 3rd semester.
Oh.
Next semester's OBPs. Cherry red lips are not normal.
When we're done, we'll give you guys some
If
tips
you
on-
remember that, you're gonna get a question on your first exam.
We'll
right?
give you guys No, we'll let you guys know some OBP. We'll give you advice on OBPs before we leave. Okay.
Do you ever use those books again once you get out of PEDS? Like, should you rent them?
I
since you're
re-
not
I
doing
rented
it?
everything from this semester on. I rented.
I
OBPs.
kept,
Okay.
I kept
Oh,
everything.
so when you
up
say
to-
we have to have all our books,
Okay.
you mean like our core
No,
books
no,
or
no,
whatever?
it says you need them, but you won't even know.
Okay. You might need porth. Those of you guys,
Oh,
if you
yeah,
guys got a
you-
porth,
I
you might
will.
need porth because you'll need porth.
You might
And
need
maybe
fourth,
your
and you might
med
need your
drug.
med
I
book.
Med
have
book.
a 2010.
Who
You're
cares?
fine.
Yeah, that's the fourth I have
I
too.
got it for like $3.
Or some kind of patho book. Patho book and a med book. That's all you need. They say that you need health assessment. I'm like, shoot. Maybe
You
Erden,
get the
maybe.
2010 version. I
You
always
used
use it.
Erden.
Super
I
cheap.
googled everything.
Well, you have
and
to
I
do
just cited.
paper. You have to do papers, but that's it, and they're easy.
So I'm like, I figured we wouldn't use anything from PED. I'm like, I think I could just rent those because it's not like you're gonna need them for
No.
community and you're not gonna
You
use
don't.
them for
Community and
needs.
mental health. Don't.
Rent.
Yeah,
Just
just
rent
rent.
Rent from now on. Okay, got it.
Alright.
Put my library.
Okay,
I'm just ready.
So, make sure you know that
OBPs. What, last semester? No,
No, fifth semester.
OBB.
fifth semesters.
this
OBPs.
semester sucks. The fattest
OBPs
dog
is so
ever.
bad, and mental health and community is
It
even
does?
worse. I would
This
say
semester because you have okay, so you're gonna go from this semester. You guys had nothing. This was the easiest semester because you have 3 freaking exams and 1 care plan, and that should
I
be
had
it.
all 4 classes.
Oh, well, I
and
took
a
on mine before.
child.
But-
and a job.
Still.
But this next semester is gonna
It's
be
gonna get
next
harder.
semester is the first time you're gonna have 2 main classes and 2 clinicals.
Yeah.
So that's what's hard. You have 14 projects and like 3 exams,
Why?
and then the
and 3 Hessies.
and then the
Oh
next
no, that's
three
fifth semester. you have
fifth
three.
semester you have 3 Hessies, 17 projects. You literally have a project and exam every week in 5th semester.
Just wanna know if you-
So my my mother-in-law's really going to raise
Fifth
my
semester
child.
sucks the fattest ever.
Fifth
She already
semester.
does.
This
And you
semester
get
was
it
the
done,
worst.
but you get it to do it on your own. A lot of it on your own.
OB peds made me hate nursing, and then fifth semester.
This
Okay,
semester maybe-
specifically peds made me hate nursing. Like if you want to be a peds nurse, just pray to God you get Maureen Tippin.
I do,
you
and
go.
I do.
Good. Then you'll like it.
I got
I don't, but I have Marine as
Well,
well.
she gave
Oh.
me this one, but she's the easy
I don't
grader.
like
No,
that, just
Michelle,
I'm gonna hate
she's
that.
nice. You just won't learn anything. She doesn't care about
Yeah,
teaching.
but
I don't want to be a pizza. No,
You're gonna
literally
I didn't hear anything
probably
bad
gonna
about
hate
Frank.
Well,
Who?
who?
Jackie said she loves
Next
Miles.
semester.
No,
Okay.
Who
I
is
got
Kim?
Oh,
Kim for pizza for OB.
peds.
She doesn't do OB, right?
I don't know who does
I
OB.
had Erickson, OB for Erickson. She's the easiest, and she lets you redo all your papers.
Cry
She
for
does you, and
growling.
she gives you. She'll be like, "Oh, turn it in early." She'll literally like write all the
Oh, I
tells
think
you what
that's
to
who
do and what to
Danielle
change.
wanted.
Erickson.
Harris.
And she's
Wait,
so
one second.
sweet. And I
She
literally
doesn't
call her
care.
to this day, and I'm like,
Oh,
please look at my
friendship.
nipples.
Okay,
Like,
Dude, I pulled her
After I
into a
had my
room
son.
and had her look at my boobs because I had this
I know
weird
something.
rash going on.
Who was
I said I'm gonna do this with the peds.
French.
Yeah.
Hold on. Oh God. French is.
Yeah, Danielle
She's
was saying
the,
You're gonna
she's
learn
gonna
a ton.
consume
That's
a
why
lot
she
of your
tried to get
time,
people
but
to
she's a
grade her.
really easy grader, and
I
you're
didn't
gonna
know
learn
it
a
was
lot.
'cause it
But
was
she's
an
gonna make
easy
you do
grader.
a lot of extra stuff. Like
Ooh.
you're gonna have to come up
French
here on days that no one else comes up here
that
and go to the sim
No,
lab and
OB.
learn everything
Wow.
before you go. Whereas the rest of us are like, here's a pregnant lady, go.
Who do we
And you just
have,
get thrown
Tony?
in. But Frencher's group was really
She
good
like
for
holds
her.
your hand more,
Who
but you're
do
gonna
you
do a little
have
more.
for OB,
I don't
Tony?
know. I don't sound
I have black shear.
No, that's your
Craft?
lecturer.
That's your
That's your
Craft.
like-
It's craft.
No.
craft
Tiffany,
lecturer.
what do I
Craft
have?
lecturer. That's your
You have
lecturer.
You have Sorn.
Soren, how's Soren?
I have no idea.
Oh, she
I don't know
night?
who I am.
Yeah.
And then who do you
I
have?
don't know.
Good things, Jenna.
For
You
OB.
have Harris.
Huh?
You guys
Chris
don't
Harris.
know.
For OB, who do you
Not
have?
I have no idea.
Ashley
Oh,
Boyd.
yours
who
is
do you
easy.
have for
Okay.
OB?
That's all I care about.
No, we're
But
with
listen,
you.
Just want someone to
listen.
tell me.
My advice is from now on, it doesn't
I
matter
don't know,
who's.
that's why I was asking you.
Listen,
From now on, it doesn't
get-
matter who's nice, okay? Because from
Take
now
the one
on,
that's easier grader.
they're gonna grade all your stuff. Your clinical instructor grades
Your-
the rest of your life from
Your
now on.
instructor no longer is going to grade anything in class. You're going to have 14 projects, and if you don't like your instructor, she's going to grade all of them.
Your clinical instructor. So
And that's
to
why
me,
she-
this is what I said.
she
I
lost
don't
her
care
A.
if they're nice. I know I lost my A in peds. I don't care if they're nice to me. I don't care if they make me cry every day. Are they gonna grade me easy? That's all I care
Because
about.
like Kim Van Slyke and I were like BFFs, man. She like sat with me at lunch. She like
She
she
grades
graduated
hard.
my mom, so we're close. And she like I got the highest grade on the first PEDS assessment in the whole clinical group, and I got a 91. And it was worth 20% of my grade. So the 91 took a hunk out.
She gave people 40%.
Holy shit.
And it's worth 14%
And
of
it's
your grade.
your first day on the floor that you're gonna walk in there, and I had a 4-day-old, and you have a like 20-page paper on that first day.
First
and I was
patient you
like,
ever have in peds. If I were you, I would get everything ready the night before, everything you need to know. Make it up. If you don't leave it blank,
Do
make
not
it
say
up.
I didn't ask if they have, because your first project's gonna be like, do they have guns in the home? Do they lock it up? Do they have locks on their windows? Do they have fire alarms?
Do they have a fire
proper
extinguisher? Do they have
car seat?
Oh, I can ask.
Is there
And
are
you
there
make all that shit up. If
do
you
they
didn't
make
ask.
money? Do they have insurance?
when
Do
I
they
Do
get-
they
live
have a
like
safe playground? How far do they live from a grocery store?
Peds.
First PEDS paper first,
You have to
and
ask
then
the parent
and then
always.
Yes.
you're gonna
This
go
is
through.
like what I get asked.
So
every
here's
time
my question.
So
Can
all
she
the
like
second
look
year.
up any of
Go
those
to the
things?
doctor.
Like, is
Look it up
They
before.
don't ask
No, like,
yeah,
can
all
she
that,
look it up? Like,
No, I mean,
Most
dude,
of
I'm
my
like,
parents never come in that way.
I just
But just go through because you're gonna get the rubric and then go through the book and look at what a psychosocial assessment would be
And
composed
then
of,
just
and
answer
look
it.
it up and look and ask. Like I asked like a
Okay,
couple questions, but it wasn't like,
this is
hey,
my
you guys
advice.
got drugs?
on mine, I mentioned the IVs. I mentioned the IVs in the IV area, but then I didn't mention the IV site in the skin area. It's redundant. You're gonna repeat yourself all the time. You have to.
Yes.
And I got marked down. I'm like, but I already talked about the IV site up here. She's like, doesn't matter.
You're
It
gonna
should
do
be part
this.
of your
You're gonna
skin assessment as
talk
well.
about what is a normal cardiovascular assessment of a 4-day-old and what did my 4-day-old have, and you're gonna repeat yourself if they don't have
I
a problem.
pasted and copied.
Copy and
Pasted
paste, copy and paste. And then where their issue is, like mine was hyperbilirubinemia. So during skin, I was like, put all the normal shit that everything was intact, but then I put that she had jaundice. Do you know what I mean? So you're repeating yourself through the whole freaking paper.
How many pages
So it's
is
like
it?
that assessment paper. We
They
did very
say a
much-
limited of 15 pages, but you clarify it because everybody that
No,
I know
listen,
limited
everyone-
it and they got awful
The
grades.
people that kept it
Mine was
under
like
15 didn't do well. The people who went above 15 got A's. So how dare you say under 15? Because my
Whoever has Maureen
girlfriend.
Tippin, she's the easiest grader in the whole world.
Yeah,
so.
for you guys have Maureen.
Is
I
she
love
really?
Maureen so much. I'm just gonna go with her.
She's
I
the best
literally felt so
clinical instructor grader.
I
She's
was
she
like,
just
"Oh,
gives
I
people
was
100%.
running."
All right.
I'm like,
Yeah.
well, maybe not your first
Does the
assessment,
grade
but
easy
all the other
fine?
stuff. If you
She's
do
just
the work,
scary.
you should get the grade. Like a
scary.
creative project, if I make you a something and it's my
bitchy.
own creative project,
doesn't
you
care
should
to
just give me
teach.
100%.
She's
If it's
easy.
my
She's
reflection on
sweet.
what I learned
So if she
and I
doesn't,
did it,
if she
give me
doesn't care to be there,
No,
we don't
they're
care to
like,
be there. We're just gonna get along great.
92. Why give me a
Yeah.
92, dude?
She good grade.
Because it didn't meet their.
She's an
reflection.
easy grader, but
The
she's
first project
Because
should be
she
the only
just
thing
like
they grade
It's
hard.
like
Because
our
I didn't want to
diagnosis.
teach, but I
It's our
was like-
diagnosis.
So
Yeah.
she was
Why-
like,
Well, as long
we're
as it
gonna
makes
go
sense.
put a Foley in a 6-year-old, and I'm like, I was the only one that ever had 2 patients. I was the only one that went to the PICU like 3 freaking times, and I hated peds, and I didn't want to do anything to do
Because
with
she knew you.
peds.
I went to
Because
the
she knew
PICU
me.
too a lot.
And then she sat with me at lunch. Okay, let's keep going, and we're gonna be here all day, and we'll talk about peds, and it'll be in a minute. It'll be
Right.
super easy, but for
Okay.
some
Oh,
reason
yeah.
last semester said it was really hard. Okay, glucocorticoids. Sugar is gonna go up 6 to 10 fold. Just make sure you know that. Cortisol levels go up with stress, pain, infection, all that jazz. We're not gonna cover diabetes because we're gonna go specifically into DKA or HHNK, but diabetes itself, you guys have gone over hundreds of times.
Alright, DK.
They're gonna ask this word, break apart the word diabetes, right?
You guys need to know.
You have
Okay,
diabetes.
type 1. Okay, you guys should have had some sort of diabetes skill out this semester, right? Or
Oh,
What?
This thing?
Last.
Some sort of what?
yeah, know that.
Oh.
Yeah,
Okay.
she gave us that.
Oh, the quiz?
Yes.
Oh yeah, yeah.
all of it?
She pulls from those. Same with like your
Alright.
sick day rules and shit like
She,
that.
she
Yeah.
even told us she was.
Baby
Yeah,
orange.
so know
What is
that.
it, baby
Did you
orange.
keep
is-
yours?
Baby orange juice.
Baby orange juice.
Yeah, I did too. But
Okay, so you guys need to know DKA. If you don't know DKA, know it now. So you have ketone production because your body's gonna break down its own fats. Fats, amino acids, whatever.
Did she ask about albuterol on the exam?
And how it what does albuterol do to potassium?
Oh,
Just
where
said
is
in the
that?
cell.
Yeah. But you do
Is
need
that
to
all we
know
need to know
that
about
they have Cosmol breathing. They're in a metabolic acidosis. The Cosmol breathing is a compensatory respiratory alkalosis. They have fruity breath. Blood sugar 300, 800.
You said the metabolic acidosis is compensating for the respiratory alkalosis?
No,
No,
the
opposite.
respiratory is
The opposite. Okay.
They have the
That's what I-
Cosmol breathing in compensation.
Okay, that's what I was like.
for.
Wait a second.
Right?
And their potassium's gonna go up, and you guys
Yeah.
already know that because of the shift.
Make sure you know that they're going to be on normal saline until 200 to 250, and then you're going to switch to D5. You're going to correct the potassium before you treat the pH if it's low.
Yeah, because if it's low and you treat the pH, it's gonna get even lower.
So then normal settings from 250 to 200 and then put them on. Yeah.
And then
Under
do
200 to 250, then you're switching them to D5.
once they
Because-
lower, because if they're coming with a blood sugar of 400 and they're running an insulin drip, you're gonna have them on normal saline. But once they get in like the 200, 250 range,
Mhm.
you can't keep them on normal saline in an insulin drip, so you're gonna put them on D5 just so we don't completely bottom it out.
Like a
Well,
buffer.
Yeah, to buffer it.
I've done, if you guys do anything in the CCU, you get insulin drips like crazy.
Yeah.
Okay,
And if you ever have to push dextrose, it's like thick and takes like 5
yeah,
minutes.
it takes forever. Okay. So, what are some signs and symptoms of hypoglycemia? Sweat, diaphoresis, tremor, tachycardia, palpitations,
Just think sympathetic
nervousness,
nervous system.
hunger, things like that. Make sure you know that. Very easy. Okay. Those are all the complications of diabetes, nephropathies, retinopathies. You guys know that.
Okay, let's go to the clinical questions.
And I think the only thing that you guys don't know here is the ABI. So a normal ABI is 1 or 1.1. So an ankle brachial index is just taking the blood pressure compared to the arm to the leg.
And it should be 1 or 1.1. So it should be 1 to 1 or 1.1.
So it's just you're just predicting peripheral arterial disease that's secondary from the diabetes. Okay. Okay, foot problems, we all know that. This is like Surg 1. Okay. HHNS. So this is super high blood sugar, sorry, over 600. Super elevated. These patients we need to be really concerned with their fluid balance.
So we're concerned with their
pee a
sugar, but we're
lot.
more concerned about their fluid balance. This is like very judicious fluid replacement.
You got to be meticulous about it because if you cause overfluid, you're gonna end up.
Blood loss.
And then needle signs.
Now we're gonna go into shock. You need to know hypovolemic shock is actually loss of blood.
Hypovolemic or hemorrhagic can be considered the same thing. It's just that hemorrhagic is a type of hypovolemic.
Yeah, possible.
But hypovolemic, you can be hypovolemic from diarrhea, vomiting, loss of plasma, things like that, burn. But if you can be.
What did we skip a lot?
Yeah.
What the hell?
She has damage control surgery for the next scene.
Oh, good. You need a no damage control surgery. Where is it?
We just went into shock, and then we go into
Well,
crystalloid.
you do need to know damage control surgery. What it is that if you're coming from a trauma, we're going to take you into the OR to stop the bleeding. So pretty much what we're going to do is we're going to
Correct.
stop the bleeding by, like, let's say we excise the spleen or whatever's causing the bleeding. And then we're going to close you up. Well, not really necessarily close you, but we're going to cover you up because we might
And then
not
we're gonna
completely
correct
close.
the acidosis, the temperature, and the coagulation issues,
Yeah.
and then we'll come back later to fix the rest.
Yeah, so pretty much what you're always going to be re-opping. So what you're going to do, the very first thing you're going to do in the OR is just stop the bleeding. Then we're going to take you out of the OR and stabilize you by, like she said, correcting acidosis because you become acidotic in trauma, correcting your temperature regulation because you're usually hypothermic, and coagulation issues. Then once you're stable, we take you back, we re-op on you, re-operation, re-op, and we then fix whatever else needs to be fixed that wasn't dire to begin with. Okay? Does that make sense? So that second time is when we do definitive care. That's when we actually do fix
Treat
you.
injury.
Yeah.
So you guys need to know that lactate ringer is what most closely resembles plasma, and that's what we use in trauma.
But you can go into hypovolemic shock from a lot of different things. People don't realize that you can go into hypovolemic shock from pancreatitis. But in pancreatitis, because of that calcium and the fat precipitation and all that, you actually draw fluid out of, and it surrounds, like you can see on ultrasound, fluid that surrounds the pancreas. And you can cause hypovolemic shock from pancreatitis. Plus you're vomiting, or you could be vomiting. You can have it from dehydration and bleeding, as well as burns.
And then the spinal cord.
Keep going. We're gonna be here forever, and I have to get my kid and pump my.
Oh,
boobs.
here's damage control. Okay, we already talked about that. Hold on, me too.
Sorry.
Okay.
Excuse me.
I gotta send this recording to someone. I'm like, what?
Well, I got a pump too. My kid's younger than yours, so I definitely got a pump.
I know, but you pumped on the way here.
Oh yeah.
Oh, I did too. I'm so tired.
Okay.
Okay.
Let's see.
Spinal cord
cord.
injury. Honestly, there is gonna be some kid riding a bike or something, and you're right, falls, hits his head and his spleen, and he's
There's gonna be a double Dewey, so it's either gonna
neurogenic
be
and hypovolemic shock. The shock ones are so easy
it's gonna be like on a horse or riding a bike, and if he falls and hits his head,
and hurts an
And-
organ.
severs an organ, he's gonna be bleeding internally, and he could be a neurogenic. So it's gonna be a double Dewey. It's gonna be just like your patho exam. But don't get him wrong and say, oh, and pick the first one. Because it's right, yeah, he could be a neurogenic shock, but he could be also in hemorrhagic shock because he, in the question says, he severed his spleen.
Okay, well, you keep looking. I'm going to go on to shit I know for sure is on the exam. With the autonomic nervous system function, you got to know that dysreflexia. So, if they have an injury...
Autonomic dysreflexia.
What, with T6 and above, yeah. And you aggravate it somehow, whether you're cleaning a wound or you're cathing or something, they're going to get like red and flushed and hypertensive above, and then cool and most and bradycardia below. So just know that. Something on the, one little easy one on the exam.
It's gonna be like something with a full bladder or something.
No, it's the answer's gonna be autonomic nervous or autonomic dysreflexia.
Yeah, but it's gonna be
I'm sure.
because
But yeah,
of either a full bladder or they're
But it's gonna
cleaning
say T6, 2 months ago, and now they have this, and this.
And what? Oh, you had that.
So know that damage to the upper motor neurons and lower motor neurons present differently. So if you have damage to the upper motor neurons, you're going to see more of like a spastic paralysis. And then if you have it to the lower motor neurons, you're going to see like flaccid paralysis. You need to know that. dermatomes, the different areas, like she said, the EMS knows, like, if you can squeeze my hand, I know you're at least, if you are able to squeeze my hand, you're at least innervated through C8. I think it's 8 or 9. And then, if you can't squeeze my hand, but you can shrug your shoulders, I know you're innervated through C5. If you can't shrug your shoulders, I know you're not innervated to C5, so what should I worry about? Breathing, because the phrenic nerve isn't going to be giving the diaphragm, supporting the diaphragm. Does that make sense? Okay. All these are patho slides, just so you
I
know.
know, keep going. Neurogenic shock we already talked about, right? So we have no longer have innervation to our sympathetic nervous system. Where we can't constrict, we're gonna dilate everywhere. We're not gonna be able to compensate with tachycardia because we're just gonna remain bradycardic because we don't have the sympathetic nervous system. It's very easy. So, hypotension and bradycardia, big thing. And they fell and hit themselves somehow. Flail chest, I know you need to know flail chest. Did anybody ever watch the end of Grey's Anatomy? When McCreary dies, they care about the stupid flail chest and not his brain.
That was like the saddest episode
Come on, nobody
ever.
gives a shit about McCreary me.
I do.
I cried. I bawled my
I
freaking
bawled my
heart
eyes
out.
out.
Oh my god.
He wants, hey, the actor wants to be a race
I've
car
only
driver.
seen 9 seasons, but I never
That's why
liked
he
Does anybody watch Criminal Minds? Because I'm so pissed that
I
Hotch
love
is gone.
Criminal
You know he kicked the writer.
it. Yeah, I know. It's the second time he did it.
Oh. Well, they should have let him get away with it a second time.
That's like the guy from,
Well,
that's like the guy from
it
Top
was the
Gear.
second time he did
Oh,
it.
yeah.
You wanna
And
watch
it is
the Top
sad.
Gear
It's
either?
like
Yeah,
one of
he's
my
the best
favorite.
one.
Yeah.
Yeah, he like punched a
I
writer or
love-
something,
yeah.
or the
As
producer.
cute as that Mexican or
The guy replacing him, yeah.
Rodriguez guy.
He's from like a
he's-
CSI or
Yeah, whatever.
something.
As cute as he is definitely no Hotch. And Morgan's gone. What's the point of
His name's
watching
I
Blue.
this
know.
shit?
I know.
Okay, flail chest, no paradoxical chest wall movement. So it's gonna move in during inspiration and out during expiration. So it's doing the opposite of like we breathe in, everything moves out. That's the opposite. That's gonna go in when we breathe in. Okay.
You need to know a pneumo. You need to know what you're gonna hear and see
We went over pneumo.
on a
already,
pneumo
right?
already.
Yeah.
We went over this respiratory, right?
Hyperresonance if there's air, dull if there's blood.
What are you gonna see in a pneumo? You might see not equal chest unequal chest expansion. You might see a tracheal deviation. What are you gonna percuss? Hyperresonance. What are you gonna palpate? You could palpate why can't I think crepitus? Yeah, or subq emphysema,
Okay.
and then auscultate.
What's definitely on the exam is ruptured diaphragm. So if you hear bowel sounds up in the lungs, means their intestines is ruptured through the diaphragm is up by their lungs.
But real quick, what kind of shock can you go in to from a tension pneumo?
Bowel sounds. Oh. Yeah, come on guys.
Obstructive.
Obstructive. Okay, obstructive. You can go into obstructive shock from a tension pneumo. How do you fix a tension pneumo?
Relieve the pressure.
Where?
Chest
So a
tube.
chest tube.
Oh, But if you're like out in the middle of the world and you
You
don't have
could
chest tube,
stab them
in the second,
with the intercostal space.
Center intercostal, second intercostal space, midclavicular line.
yeah.
Did she tell you about how she had to do that once?
No.
Oh gosh, the resident tried to get an art line and then nicked him, and then he went to the other side, but she didn't. She's like, no, we need an x-ray, we need an x-ray. He's like, we don't have time. Went to the other side, nicked that one, blew both of his lungs, so they had to do at the same time. He's like, come on. And she's like, this is out of my scope practice. She had to get permission and everything. He had to like do this big verbal, and they both did it.
Whoa.
Hey.
A chest? She put a chest tube in?
No,
she
just
just
a
had the
catheter.
needle
Okay.
catheter.
Because
Okay.
they're gonna die.
It's like a pressure valve. It lets the air out, but not vacuum.
Yeah, because them Sockham guys can do it. They can do everything. The guys in black, Sockham,
Yeah,
the cute
okay.
ones, the really hot ones.
All the
Military
guys. Okay,
That's like a
pericardial,
rule.
tamponade.
It's so calm.
They were happy when we let them do an IJ.
I always call them Sockham. They always call them Sockham.
It's so
I
calm.
like the fanny packs.
Oh, they all call them Sockham. Sockham guys.
Okay,
There's
you guys gotta know
there's-
Beck's triad. That's on the exam for sure.
They're special forces medics.
Beck's triad.
They're not doctors, but they can.
They're field doctors.
They're gonna.
It's JVD, muffled heart sounds, and hypotension. That's the Beck's triad. So make sure you know that. Literally, the answer is gonna say which of the following is Beck's triad or something.
What?
Say that again.
Beck's triad.
Is she gonna ask this question about somebody's in a MVA and they hit the steering wheel?
Where is that?
No, not the
It's
same way.
pericardial tamponade slide.
Oh.
Pericardial
blunt aortic injury. Oh,
right?
the blunt aortic injury. Know that doesn't it sound familiar to you? Deceleration causing the ligamentum arteriosum to tear the wall.
Sure, it does kind of.
Okay, so the ligamentum arteriosum you're going to learn all about next semester in OB is attaches the aorta to the
There it is.
pulmonary some of the pulmonary vessels. So it's specific. It's right there.
Oh, there it is. Yes, I have it
Yeah.
highlighted.
So when you have like an ascending descent, like when you stop real quick, pretty much in a car accident, you can tear, and it can cause a shearing dissection
at
of
the
the aorta.
ligamentum arteriosum.
You'll know all about it in OB, what that ligamentum
Carmen syndrome, I
arteriosum.
feel like none of this is on there. She wants you to know, this is like my notes. Wide mediastinum indicates possible dissection. I don't really know what that means. High riding prostate and blood meatus, think urethral injury. 4 to 6 units for the pelvis, 2 units for the core. Random notes, she just repeats herself. Oh look, high riding prostate, blood meatus.
You know, where are you? Fat embolism.
Right here. Oh
You
yeah.
know about fat embolism. If
Yep.
your patient had a long bone injury and is now having respiratory issues and has that rash on their trunk, it's like a petechiae.
Respiratory failure, confusion, and short-term petechiae. Think fat embolism. Unfortunately, there's not much we can do for those people.
Especially if they just had a long bone injury.
What is?
It's when fat goes in. It's like a PE, but it's fat. You know.
No, what is these?
And then
Oh, it's down here below. Okay.
You don't need to know that. You
cardiovascular.
don't need to know that. Guys, just know the gist of your shocks. Hypovolemia, your pressures are low, you don't have gas in the tank, you have a low preload, right?
You're losing it somewhere or not getting it.
Cardiogenic, you either had a massive MI or you're just in heart failure, your heart's not pumping, that's why you have no blood pressure.
But you have volume.
Yes, obstructive shock is everything's working, something's being obstructed because of a cardiac tamponade.
So
or
the heart is
tension
being
pneumo.
obstructed specifically. So the heart can't do its job even though it's physically able to because it's being obstructed.
Distributive is widespread vasodilation. Now you just need to figure out where it's from. If it's neurogenic, it's because you don't have innervation to your sympathetic nervous system. If it's anaphylactic, it's because you ate a peanut and now you have histamine release all around and you bronchoconstriction. And then septic is because of the inflammatory mediators, you have vasodilation. As long as you know the gist of that, the questions are super easy on shock.
Cool.
And then you just would know the treatment. Hypovolemic, give back volume. Cardiogenic, fix the heart. Obstructive, remove the blood or the air. Distributive neurogenic, there's not much you can do, so you're going
You're
to
going to
use
have
pressors.
pressors and you're going to have antibiotics if it's a sepsis.
Yeah, sepsis, antibiotics, and they're all pressors for distributive because you need to counteract that dilation. And then anaphylaxis is going to be
Epi.
something epi, and then yeah, epi. Okay. I never did anything.
I mean, Stevie Johnson, are you kidding me? It's like disgusting.
Have you seen it?
No, but it's, you've
No,
seen pictures of
you
it.
have to know that SIRS is 2 or more of those 4 clinical manifestations. So if they have a temp under 38 or over 38 or under 36, heart rate over 90, respiratory rate over 20, white blood cells over 12, you guys should have a slide. So they have to have 2 or more of those to have SIRS.
Anything about compartments?
Well, compartment syndrome, just know that pulse is the last to go, is the late side. You can have compartment syndrome, you can have with trauma because if you, especially in your abdomen, if your organs and everything starts to swell, so you need to know that extreme pain. What are you going to do in a trauma if there's a lot of swelling on their leg, for example? You're going to do what? Fasciotomy. You're going to open it up. They'll actually do an open lap and then keep patients open after trauma because they know there's going to be swelling of those internal organs.
We never clocked in. We're just doing this for free. Who cares? Okay.
Well, $20 we would have gotten.
Stevie Johnson, make sure you just know the bolded thing because it starts off as like a little lesion and then all of a sudden all their skin falls off.
Not all.
Most of it.
It just sloughs off. And then what are common drugs? Sulfa and Dilan. I write down.
Oh, that's right.
You say you have to have 2 or more for the Surg?
Yeah.
And then just so you know, you're gonna have some EKGs, but it'll be in your exam with context. So like hyperkalemia, things like that, okay?
The hyperkalemia is the one from the book. The
Remember-
peaks T-wave is the one in the book.
Remember when you guys thought last exam was really hard and then we're like, trust me, you guys are gonna be fine? You guys are gonna be fine.
You guys are doing great. It's just, I mean, it's way longer. It's like 100 questions or something crazy. But there's gonna be a PA probably still, and then there's gonna be a torsades probably, like the same ones you get every test.
No diabetes. Know your diabetes, know your shocks.
Yeah.
So I'll get DPA.